All right, thank you everyone for watching this video, getting prepared for the next exam. Let's go ahead and just jump right in. So like we had talked about in class, the way that we're going to break up our discussion of different substances is into three primary categories. The first category that we're going to talk about is CNS depressants or downers. So it's important to understand just kind of the basic substances that fall into this category because all of them are going to have similar outcomes, kind of similar effects overall, even though the actual expression of them is going to be a little bit different. The risks of abuse and addiction and things like that with them are all going to be a little bit different. But again, just kind of understanding the general process that they all kind of fall into the same category is helpful. So what falls into the CNS depressant category? Well, we have alcohol, opioids, benzodiazepines, inhalants, and cannabis. This is not a comprehensive list, but these are the kind of major hitters in this category. So let's talk about alcohol. So like we talked about, we do have to understand that not all substance use is abuse. So understand that just because someone says that they are consuming alcohol regularly does not necessarily mean that they are addicted or that they are an alcoholic or that they need to cut down or anything like that. We do have specific recommendations for what is considered low-risk drinking. So that is, for men, it is less than 4 drinks in one day and no more than 14 drinks in a week. For women, it is no more than 3 drinks per day and no more than 7 drinks per week. So remember, they have to meet both the criteria for this to actually be qualified as a low-risk drinker. We also talked about the definition of a drink. So it's helpful to just have this access to this, when you're actually talking to patients about this to discuss kind of what is considered a drink, because this might be a little bit different kind of depending on, what their experience is, or what their drinking habits have been. We can also look here and kind of see most of the population falls into that low-risk drinking category, low-risk or abstinent, meaning they don't drink at all. But we do see that, again, this isn't just a clear division between, you're either a low-risk drinker, an abstinent drinker, or you're an alcoholic and you're a problem drinker. There is a gradation to this, and there is some variance to it. So we need to kind of understand that, too, that just because I have a patient who is taking the audit and they score, let's say a 10, which is an indication for risky drinking. That doesn't mean that I need to panic all of a sudden. They need to go to rehab and, start looking up their local AA meetings or anything like that. It just means that there are some habits that maybe are putting them into that risky category that we can educate the patient about and help them kind of maybe come up with some strategies that can help reduce that risk. So again, this is not trying to shame anyone, and it's not that clear division between just making someone either kind of putting them in the bucket of either an alcoholic or a non-alcoholic. So just kind of keep that in mind when you are doing, teaching with patients in the future and kind of using that SBIRT model that we've talked about. Now with opioids, this is a list of some different types of opioids. Basically, I want you just to kind of understand that there are a lot of different forms of this, a lot of different types of opioids. There are different brand names for a lot of these. A lot of times these are used kind of interchangeably. Just kind of understand that there are several different types of opioids. These include things like heroin, which is an illegal substance that is usually categorized as a street drug. It's not something that's going to be prescribed, but it is also prescription drugs like oxycodone or hydrocodone. Most individuals who wind up becoming addicted to a substance like heroin or begin using heroin started off with a prescription medication. So depending on what study you're looking at, it's somewhere around the 80 or 90% of individuals who are currently using heroin started off with a prescription medication. So keep that in mind, that this is not always just the addicts that we think of. I don't personally like that term. because there is a lot of negative connotation that comes with it. There's a lot of judgment that comes with it. Like we talked about in class, we were talking about individuals who have a substance use disorder, and that can be anyone. It can be a married mom who is, part of the PTA that is addicted to oxycodone because of a back injury that happened 10 years ago. It could be a healthcare professional that, had some kind of nerve damage and is now, maybe skimming a little bit off the top of their patients' medications. There are all kinds of ways that this can look. And so don't kind of get it in your mind that like, oh, there's only certain people who are at risk for this. This can literally affect anyone. And in Utah in particular, in 2016, Utah ranked number 4 in the nation for deaths due to opioid-related overdoses. So we are not anywhere near immune here in Utah. This is absolutely something that is happening in our state. So I do want you to also be familiar with naloxone. So naloxone is a life-saving drug. It's an opioid antagonist. Essentially what it does is it actually reverses the effects of an opioid overdose. The way it does that is by actually competing with opioids for opioid receptor sites. So we talked about some of the things that downers do in class, and one of the things that they do is they basically suppress all of the activity in your central nervous system. So that's going to include things like social inhibitions, coordination, but it's also going to suppress things like your respiratory rate, your heart rate. So what is often happening with an opioid overdose is the patients are actually stopping breathing because their CNS, their central nervous system, is so depressed. This opioid antagonist actually competes for those opioid receptor sites and actually blocks other opioids from coming and activating those sites. What then happens is the patient actually starts to feel less of the effects of the opioid, so they are able to reverse the overdose. This can be delivered a couple of different ways. There is a nasal spray, which is one of the more common ways. It's a lot easier, less invasive, but there is also an IM injection. Now, this is a pretty short-term medication, so it only lasts for about 30 to 90 minutes, and it usually starts working within a few seconds. So if you have a patient that is suspected of an opioid overdose, this is a very safe medication to give them. There's almost no negative side effects of this medication, in part because it gets out of your system so quickly that even if you have a patient who you suspect had an opioid overdose, administering naloxone is going to be a life-saving measure. So even if we're not positive that the patient is suffering from an opioid overdose, administering naloxone is a very safe bet. So we also want to talk about cannabis. So cannabis, one of the things to talk about here is just kind of the naming convention. So cannabis, the more common name is going to be marijuana. Cannabis is a more clinical term, and it has a little bit less baggage with it, and so that's the terminology we're going to be using in this course. But we also need to make sure that we're talking about the active agents in it. So there are very specific active psychoactive agents that exist in cannabis. These are usually classified as cannabinoids. The two that are most common, or that are talked about as the most common, or kind of like the biggest names in this, are TCH and CBD. So there are two major types of cannabis, or two kind of major strains of cannabis. That's indica and sativa. Now, these have kind of different effects based primarily on the combination of THC, CBD, and other cannabinoids they have. So if we look at sativa, this is usually what is termed as the head high. This is more CNS stimulating. It has a higher THC ratio. You see on the graphic here that we have things like it increases creativity, euphoria, it is energizing, it causes alertness. Then if we look at the indica side of this, we have what is more CNS depressing. So this has a higher ratio of CBD. And this is what we see as kind of the body high. So this helps out with relaxation, kind of like chilling out. This can help promote sleep. I think that it's important to kind of understand that there's a variety of effects that cannabis can have. Not all of this is super well understood, partly because we haven't been studying cannabis in clinical settings for very long. But, given that, we are having an ongoing debate in Utah of kind of like what level we're going to legalize cannabis, and also that a lot of our neighboring states have legalized recreational cannabis. I think that this is important for us as nurses to understand. The last category that we'll talk about in here is inhalants. So inhalants is kind of a catch-all, mostly because what we're describing here is a way to administer the psychoactive drug instead of the psychoactive drug itself. So a lot of times people are going to use things like solvents or adhesives, fuel, lighter fluid, video head cleaner, permanent markers, paint, whipped cream canisters. All of this can be used to get a psychoactive effect. This is usually like described as huffing or sniffing or bagging or dusting, a lot of different things. This behavior is almost exclusively seen in adolescents, mostly because it's more easily accessible. When done in excess, this can lead to kind of longer term brain damage, but typically there isn't a ton of damage that can happen in the kind of short term. The thing that we're most worried about is kind of the other injuries that come as a part of this. So if someone is huffing and they lose consciousness and then hit their head, well, then we're worried about the head injury. Again, like this isn't something you want to encourage anyone to do. It's also not like the end of the world if someone has done this once or twice. But the thing again here is that we're most worried about overall physical safety. So when someone is going through withdrawals, what we need to kind of look at is kind of the CNS system as a whole is always trying to strive for homeostasis. So it's always trying to have a balance between a stimulating neurotransmitter and a sedating neurotransmitter. So an inhibitory neurotransmitter and excitatory neurotransmitters. But what happens is if we start to maybe introduce a large amount of a substance that is inhibitory in our body, that artificial substance is acting as that inhibitory neurotransmitter. And what our body does in response to that is trying to achieve homeostasis. It actually puts out more of the excitatory neurotransmitters. And this is what we see with the kind of instances of tolerance. We see an issue with our body is developing kind of mechanisms to balance out, to achieve homeostasis. So people need to start using more and more of a substance, more and more of that artificial substance to actually act on the central nervous system in the same way. So what happens when we completely take away that artificial inhibitory neurotransmitter? Well, we have a lot of things that happen. We have things like physical body tremors. We see basically kind of the opposite of what the medication was doing or what the substance was doing. So we see some hyperactivity happening. We see things like hypertension, tachycardia. Body aches and pains will be common. Insomnia and anxiety are very common. And in very severe cases, we can have delirium tremens or DTs. And these can be things like seizures or things like hallucinations. Seizures are the main thing that we're worried about here. When there is so many excitatory neurotransmitters actually active in the system, seizures can be one of the biggest things that we're worried about in a detox situation or in a withdrawal situation. And this is part of the reason that individuals who are withdrawing from CNS depressants are almost always going to require some type of hospitalization. They need a higher level of care. You again, are really, really going to need to stress this with patients that are trying to detox. If a patient is trying to detox at home off of alcohol, that leads to a lot of safety issues. And what also happens with detoxing, in particular from CNS depressants, is that there is almost always going to be a cross taper of a medication that is required along with close medical monitoring. So this cross tapering is where we're going to introduce a medication that is similar in effect to, like, let's say, alcohol. So a medication that is similar to effect in that is a benzodiazepine. However, a benzodiazepine has a very predictable duration, a very predictable action in the body because it's been laboratory developed to have that response. So we give patients a progressively smaller and smaller dose of a benzodiazepine as they're then starting complete abstinence from a substance like alcohol. Again, close medical monitoring is really important here, but kind of understanding that these physical symptoms are usually more severe than the psychological symptoms that come with them, at least initially, is important. So what are some of the considerations or accommodations or approaches that nurses should have when they're working with individuals suffering from CNS depressant withdrawal? Well, I hope everyone was yelling safety really loud, because safety, again, is going to be one of our major concerns. So we are looking out for, all of our seizure precautions. We're also understanding that these individuals may feel jittery or hyperactive. They're going to feel like they kind of can't sit still, like they are having that difficult physical response from getting off of these substances. What we need to also do is make sure that we are really firm in following the rules and avoiding any kind of manipulative behavior on the part of the patient, that we're encouraging follow-up care, and that we're basically understanding that the withdrawal is really severe and difficult to get through, but it is only the first step in this process. So let's talk about CNS stimulants or uppers. So with uppers, we have things like cocaine, amphetamines and methamphetamines, MDMA, or the other name for this is ecstasy or Molly, nicotine, and caffeine. So what are some of the things that a CNS stimulant is going to do? Like, what would we expect to see happen in individuals who are taking a CNS stimulant? Well, what we expect to happen is kind of all of the opposite of what we would expect for individuals that have been taking a CNS depressant. We expect that individuals are going to, actually, let me go back a slide. We expect that people are going to feel less tired. They're going to feel more alert. They're going to be kind of hyperactive, hyper-focused. We expect things like anorexia, again, anorexia, the symptom, so a decrease in appetite. We expect that they are going to have a higher blood pressure, that they are going to have tachycardia. Sometimes we can see compulsive behaviors. Sometimes there's muscle twitching. In very severe cases, you can also have psychotic features, because what a lot of these uppers are doing is they are increasing primarily dopamine in the body. So when we have an excess of dopamine in the central nervous system, what we would expect is episodes of psychosis. Remember, this is kind of the theory behind what is biologically happening with schizophrenia, that there is too much dopamine available in the system, and so the patients are starting to have those episodes of psychosis, those positive symptoms of psychosis. So when an individual starts to withdraw from this, what we would expect is kind of to see the opposite of all of those. So we see things like lethargy and fatigue. We see hypersomnia, individuals needing a large amount of sleep. There are still body aches and pains. We see things like depression. Tachycardia is one of the only things that stays consistent. So, we don't see that cardiac depression in these individuals. Sometimes there can be acute psychosis, which is also kind of the inverse of what we would expect. But usually there's not any cross taper that's needed. So you don't usually need a medication substitute for individuals to come down from this substance. Very similar to individuals who are taking a CNS depressant, a lot of times what will happen is the body will actually create more of those inhibitory neurotransmitters to counteract the excitatory artificial neurotransmitters that are being introduced. But what ultimately happens is individuals just need rest. You just need to be able to kind of sleep it off. And that's kind of what we need to expect as nurses. So when we're planning out nursing care for these individuals, we need to kind of understand that they are going to need a lot of extra sleep. They're probably going to also need a lot of rehydration and a lot of food intake. Usually kind of the idea that you want to keep in mind is this idea of borrowed energy. We only have a finite amount of energy. Our bodies can only go for so long just automatically by themselves. So when you're using a CNS stimulant, what you're doing is you're borrowing kind of against that energy. You're not just creating new energy, you're taking energy away from your future self. So what's happening when you're detoxing off of those, when you're withdrawing from those, is you need to get that energy back. You need time to rest. We also need to understand that individuals might have slower cognition, slower kind of responses. So kind of understanding that patients might need a little bit of extra time to complete kind of simpler tasks, to kind of understand discharge teaching. They actually might physically feel slowed down. So keep that all in mind with your planning. Now, when we're looking at detox versus rehabilitation, really kind of the major difference here is the amount of time. So detoxification is usually 1 to 2 weeks, and it is restoring a physical homeostasis in the body. It is very much focused on managing those withdrawal symptoms in a safe environment. Rehabilitation, though, is a longer-term process. This can take months to years. It can even be lifelong in some cases. And this is a long-term process that is focused on the psychological end. So detoxification focused on physical homeostasis. Rehabilitation is focused on that kind of long-term restoring psychological functioning, avoiding relapse. There can be pharmacological treatments that are a part of both of these. When we're focused on detoxification, these pharmacological treatments are mostly going to be focused on managing those symptoms of withdrawal. Whereas, again, in rehabilitation, we're focused primarily on avoiding relapse. And so medications, those pharmacological treatments that we're using, are aimed to decrease incidence of relapse. Again, in detoxification, you do require close medical monitoring, and in both of these, it's highly encouraged to utilize individual therapies, group therapies, peer support groups like AA. So AA is one of the oldest peer support groups. It's based on the abstinence model. Basically, this is a group of non-professionals who help each other support one another through kind of this one day at a time mentality of trying to get to complete abstinence and trying to maintain and avoid relapse. It's important to understand that, like with AA and any of these peer support groups, there's not one in particular that has shown to be the most effective type of treatment. really with all of these types of rehabilitation, it is incredibly individualized. The kind of rule of thumb is try everything and see what helps. For some individuals, AA is going to be really helpful. For other individuals, it's just not. And we kind of don't know exactly what is that difference, what makes someone more prone to be successful in one versus another. Okay, the last category of substances we're going to talk about is hallucinogens. So hallucinogens have several different things that fall into this category. We have things like LSD, or another name for this is acid. We have psilocybin mushrooms, or sometimes these are called magic mushrooms or shrooms. Other things that fall into this are things like ketamine, peyote or mescaline, DXM, which is an ingredient that's found in some cough syrups, nitrous oxide or laughing gas, ayahuasca, salvia, all fall into this category. So the way that these work is basically they are altering or disrupting or mimicking activity of serotonin and dopamine. So when they're doing both of these together, they are creating some hallucinations. Now, usually these sensory perceptions or these alterations in sensory perceptions are not as distressing as they are in kind of classic psychosis, like we would see in individuals who are suffering from schizophrenia per se. Partly because of the other effects of these medications, or of these substances rather. So you have, you start to have what's called cognitive flexibility, this kind of changing in alteration in perceptions, but also a changing in maybe the way that you are thinking about certain things, the way that you understand certain things. You start to see different types of connections. You start to think about things in different ways. Like I said, you can have hallucinations. You can also have euphoria. A lot of times there are memory alterations that occur with this. You usually have some of the similar effects to alcohol in that you have things like decreased muscle coordination and decreased social inhibition. You can also have other negative side effects like paranoia or emotional lability. So this is kind of a grab bag. Sometimes there can be times where you have a really fun, awesome experience, and there's other times where you can have a very scary, bad experience. Usually the terminology that's used a lot of times with hallucinogens when someone is having an active episode on a substance is a trip. And so you can have a good trip or you can have a bad trip. And it's kind of difficult to describe, is this one or is this the other? How do we know when we're experiencing one or experiencing the other? So what kind of accommodations do we need to keep in mind for patients that are experiencing this? Well, typically there's not a detox that is actually needed for this. So the only time that you're really going to see individuals is when they are having a bad trip and the hallucinogen is still active in their system. So what we need to kind of keep in mind is that we just need to help them through the trip. There's really not anything in particular that you can do that can be helpful to make the experience faster or to get it to wear off quicker. You just kind of have to let it run its course. So what a lot of what we're doing is just kind of offering observation and support. So we want to make sure that we're placing the patient in a calm, quiet area. We want to make sure that we are pushing fluids to either restore or maintain hydration. If the patient is hypothermic, we can, or rather, if the patient is hyperthermic, if they are starting to feel too hot, we can put cooling blankets on them. If the patient becomes comatose, obviously we're going to be supporting their airway, maybe administering O2. We could also be administering naloxone if the patient is comatose, or if we suspect that they have also been using opioids. If the patient becomes aggressive or combative, we can use other substances like a benzodiazepine and an antipsychotic cocktail to kind of counteract some of that aggression. But again, the difficulty here is that there's not anything that we can do that will stop the hallucinogenic substance in their system. We just kind of need to let it run its course, and that can be anywhere from 8 to 12 hours. So just kind of offering that supportive care is the best that we can do. So the last thing that we'll talk about here is going to be addictive behaviors. And I put addictive here in quotation marks, partly because, like we had talked about in class, addiction and the word addictive is kind of a harder thing to kind of pin down. We understand that there are certain behaviors that are associated with it, like the kind of compulsive behavior where you don't want to stop doing something even though there's negative consequences of it. That time-consuming behavior that you spend a lot of time either trying to obtain the substance or trying to do the activity. We also understand that there can be things like that unsuccessful attempts to reduce the usage. So really kind of what we're looking here is more at this idea of impulse control, of not being able to control our desires to act on a certain thing, to steal or to set fires, to gamble, to look at pornography. Really, I think that if we start to look at this too much as the addiction model, kind of the disease model of the brain that we're using for addiction, mostly now, this idea that, this isn't a lack of willpower, it's, this evil substance that's gotten into your system. I don't think that we can say that it's all one way or all the other. I think that we have to understand that there are certain things that our brains are kind of built for, these dopamine hits and releases that we crave and we desire, and those can lead to these compulsive behaviors. But, we can't at the same time say that it is only dependent on that, because not everyone who gambles is addicted to gambling. So just kind of keeping in mind that there are certain behaviors that we just don't really have enough information about to say whether or not these are kind of classic cases of addiction. So a new disorder that has just been introduced to the DSM-5 is gambling disorder. Other names that were considered for this were compulsive gambling disorder or problematic gambling disorder. But there are other disorders that we still just don't have enough information on. Things like compulsive sexual behavior disorder, internet gaming disorder, things like shopping and eating. These are things that still need more research behind them, and we need to understand more about them before we're really classifying them as addictions or when we're pathologizing them. Again, this is the kind of tricky balance of making sure that we are getting help to the people that need it, while we're still not saying that people are sick when they're really not. So let's look at some questions. So tolerance to a substance occurs, A, if the substance is used inappropriately, B, when a person has developed both a biological and psychological dependence on a substance of use, C, when the body begins to rely on a substance for regular functioning and abrupt discontinuation would result in withdrawal, or D, when a progressive increase in the amount of the drug is required to obtain the desired effects. So remember, this question is specifically asking about what tolerance is. Oops. So the correct answer here is going to be D. So tolerance is when more and more of a substance is needed to get the desired effect. When you start to when your body begins to rely on the substance for regular functioning, that is going to be physical dependence. So when withdrawal is present, that's physical dependence. B, when a person develops a biological and psychological dependence on a substance, that's usually what we're talking about with addiction. And then A is kind of a more judgmental way of talking about addiction. That's going to be a not preferable way that we want to talk about it. Okay, last one. Leon is a patient at your OBGYN clinic. During a reproductive systems assessment, Leon mentions that she had recently been recently stopped by the police and got her second DUI, but minimizes the consequences of this legal issue. What nursing intervention or action would be best to take first in this situation? So A, use the CAGE questionnaire to assess Leon's alcohol use. B, notify the physician and the interdisciplinary treatment team. C, refocus Leon on the assessment questions related to her reproductive system. D, document the comments in Leon's EMR. Or C, use the CWA questionnaire to assess Leon's alcohol dependence. So A is going to be the correct answer here, because the first thing that we want to do is we want to assess her overall dependence on alcohol, kind of like what is the level of usage that she has. So the CAGE questionnaire is a good way to do that. It's a simple tool that can be used to assess kind of the severity of someone's alcohol usage. It shouldn't be the only tool that we're using, but it's something that we can use quickly in the moment to ask Leon about her alcohol use history. B, C, and D are all things that we are going to want to do. Not C, rather. B and D are things that we want to do for sure. We want to absolutely document this. We absolutely want to talk about this with the treatment team. However, they are not the first things that we're going to do. And then E, using the CWA questionnaire, that is actually going to be, the CWA is used when we are assessing someone's withdrawal symptoms, not when we're assessing someone's alcohol dependence. Okay, so I hope that this has been helpful. If anyone has questions, please feel free to email me. If not, I will see you all in class.